Well, thank you, and thank all of you for joining us here today. I appreciate everyone who's been on the panel, and I certainly would be remiss if I did not also offer my congratulations to Representative Kennedy, Representative Brooks, and all the other members of this great subcommittee and great committee who are going to be leaving us. We're going to be losing some valuable members with great institutional knowledge, and we certainly will miss all of them. But I want to begin by addressing the situation that continues to be a problem. And that is, my colleagues across the aisle seeming to want to communicate or seem to want to put a message out there that Republicans are not wanting to protect pre-existing conditions. Nothing could be further from the truth. And I think you all realize that. And that is something that we have worked on and we continue to work on. In fact, if we look at the present Congress that we're in, the 116th Congress, one of the first floor votes that we tried to have was to try and protect those with pre-existing conditions. So I want to reiterate what's been said by a number of my Republican colleagues on this subcommittee here today, and that is that we are in favor of pre-existing conditions. We continue to be, we have been, and we will always be. We understand, particularly in the trying times that we are in now, with the problems that we're having with the pandemic, we understand how important covering pre-existing conditions are. Dr. Holtz-Eakin, in your testimony, you mentioned that through June, there were 6.2 million workers who lost their employer-sponsored insurance due to job loss from the pandemic. And President Trump has worked to make short-term limited duration plans available to beneficiaries for up to 36 months, providing certainty and continuity for patients. Previously, the previous administration had made them available for only 3 months. How can short-term limited duration insurance plans fill the employer-sponsored insurance gap? And is there any indication that they have?
So as I mentioned earlier, we don't have a great data on what's happening on the ground right now. So I can't answer with any sort of definitiveness how many people are taking up short-term plans versus other options. But it is another option on the table. It's an option that was not available previously. It might hit a price point that is better than a price point on the state marketplace, and that would be a very valuable option in this situation.
And wouldn't you believe that it would offer patients more flexibility and affordability in coverage?
Certainly, there's a greater variety of plan designs out there. That's one of the advantages. The concern that you've heard voiced is that people won't understand the plan design they're buying, but certainly there ought to be a way to do good consumer education, get them in a plan that's good for them.
Well, I believe this committee in general, has addressed that before. In fact, I know that I have advocated for us to publicize these plans more so that people would be educated as to the availability of these plans and how they could help them. But unfortunately, the other side of the aisle, again, are opposed to these plans and did not want to offer education to our citizens as to the availability of these plans. Let me ask you also, Dr. Eakin, given that premiums have more than doubled during the time that the Affordable Care Act was signed into law, what are your recommendations for how we can reduce the cost of health insurance and allow people to shop for coverage that might best fit their needs?
There are really two broad strategies. The first strategy is to provide greater competition in insurance markets, lower the barriers to entry, allow more products and variety, and allow people to choose among them and thus get a plan that fits their economic situation. The second strategy is to deal with the underlying costs and value proposition in the delivery system. And certainly there's a lot that Congress can do in that area through the big payment silos that are in Medicare and Medicaid, which really drive the delivery system in the United States. And some of it can be done at the local level, state scope of practice, state certificate of need, all sorts of limitations on competition need to be addressed. I think the telehealth example is the best example of how the over-regulated U.S. healthcare system couldn't respond flexibly to the pandemic, and it was only the emergency waiver of a lot of regulations that allowed telehealth to prosper. That should be made permanent. I mean, that's going to require legislation. That's a great opportunity going forward, and I'd encourage the community to look at that.
So you would agree, just as the free market has worked in our society, that the free market can work in healthcare to lower healthcare costs?
Certainly, if you have high prices, you have a supply problem. You got to look at the conditions that are limiting supply.
Well, thank you very much, and thank you, Madam Chair, and I'll yield back.